Hi everyone. All right, let's get started. Today's presentation is titled Reproductive Trauma is Medical Trauma, Reframing Women's Health. So, trauma occurs when we are no longer able to envision our future or feel safe. It can be a one-time horrific experience or it can be chronic in nature. Reproductive trauma can be both of these types of pain. It can be the frightening and painful loss of a miscarriage, massive bleeding, and need for emergency surgery, or it can be the seemingly endless cycles of hope and despair during fertility treatments. So here are our learning objectives for the day. After this presentation, you will be able to identify different forms of reproductive trauma, recognize their signs and symptoms and how they meet clinical diagnoses or don't, and then identify possible treatment outcomes or treatment options. First, quickly, let's just talk about medical trauma as a whole. Medical trauma is defined as trauma that occurs from a direct contact with the medical setting and develops through complex interactions between the patient, medical staff, medical environment, and the diagnostic and or procedural experience that can have powerful psychological impacts due to each patient's unique interpretation of every event. Medical trauma is not black or white, nor is it easily detected. Like I said, every patient has a very unique experience of each instance that took place. Medical trauma is biopsychosocial spiritual, meaning that it happens on multiple levels within the body and the patient overall. So it affects the body's integrity through illness or injury. It causes a psychological response, causes trauma socially, having to continue to see medical staff and family. And it can affect their spirituality, especially if and when they are facing death, if this medical illness is terminal and or emergent. So now moving to specifically reproductive trauma, as defined by Dr. Janet Jaffe, who is a clinical psychologist and the co-founder, co-director of the Center of Reproductive Psychology. She defines reproductive trauma as the stress of negative reproductive events, including fertility, miscarriage, stillbirth, and traumatic birth experiences. It causes a significant threat to an individual's emotional and physical well-being beyond available coping resources. Reproductive traumas are associated with lower quality of life, marital discord, complicated grief, major depressive disorder, anxiety disorders, post-traumatic stress disorder, and occurs in up to 15% of women as trauma. Reproductive trauma, like we said, it can be a one-time horrific experience or it can be long-lasting, and traumas can also run concurrent with each other. Let's just say a woman experiences a miscarriage during her infertility, so she's had cycles of hope and despair, and then she gets pregnant, and then she loses that pregnancy. We have two traumas running concurrently to each other, and that can be emotionally devastating for everyone involved. So reproductive trauma looks like a few things. It looks like miscarriage, which is the loss of a pregnancy prior to 20 weeks. This happens in 15 to 20% of pregnancies and results in the mother with feelings of shame, guilt, intense grief, self-blame, feeling like a failure, because you just don't know why. You don't get an answer a lot of the time as to why you lost the pregnancy you did. And then it can also look like a stillbirth, which is giving birth to a non-living child after 20 weeks of gestation. And this happens 6 out of 1,000 births in the United States, which seems low, but think of how traumatic that is to then go through a birth and you don't get a baby, you don't get your baby after. This leaves the woman feeling intense grief, guilt, and self-blame. What did I do wrong? What happened? Where did this go wrong? How did this happen to me? And then there's traumatic birth experiences, which is seemingly the most complex, and also the most relevant. 1 in 3 women experience a traumatic birth. That's astronomical amount, and it can be contributed to several factors. There can be physical factors to this, and that would be, let's say, an emergency C-section, instrumental vaginal delivery, a hemorrhage, preeclampsia, an unplanned hysterectomy during childbirth, and then it could be something like separation from their infant, that has had to go to the NICU, and has been there for quite some time, and the mother has to go home without her baby, but the baby is in the hospital. That can be very traumatic for a mother. There can also be psychological factors, such as reliving previous sexual trauma during childbirth. So if a woman has experienced sexual assault in her lifetime, and those emotions and memories and everything can come flooding back during childbirth, therefore making the childbirth itself traumatic for her as well as reliving previous medical trauma. So if she's had other conditions that have put her in medical trauma before, she's reliving those during childbirth. There's also care-related interpersonal trauma, which is basically just feeling disrespected or unheard or not seen by healthcare workers. You could feel pushed, you could feel coerced, you could feel rushed, abandoned or alone. They could be getting scolded by medical professionals. There could be poor communication. There could be like blank threats made. If you don't do this, your baby won't get this. So, trauma can come from the people within your medical experience too, not just the medical experience itself. Women who experience a miscarriage or a stillbirth or a complicated birth are more often to experience the reluctance to become pregnant again. If you have lost a baby, it can be very hard to convince yourself to go through that again, to get pregnant, to carry a baby. If you had a stillbirth, it can be very hard to convince yourself to carry a baby again, not knowing if it's going to make it to full term, and you never want to feel those feelings again. So there's definitely always reluctance there to go through it again. Reproductive trauma, in a way, can also look like infertility, which is the inability to conceive after 12 months of regular unprotected intercourse. That's for a couple younger than 35 years. For a couple that is older than 35 years, it's 6 months of the inability to conceive. And this happens in 9 to 15% of the childbearing population, and that's just the diagnosed infertility. Infertility can result in just feeling like you've lost all control. You isolate socially, very low self-esteem. Why can't I do it? Why can't I do it right? This is what my body's supposed to do. Why can't I do it? It can leave them with serious feelings of depression and anxiety, which leads us to the last form of reproductive trauma we'll talk about, which is postpartum mood disorders. Postpartum mood disorders are a significant public health concern. Within the first year after childbirth, it's a time of immense physical, hormonal, and psychological changes within a woman that can result in the development of postpartum depression, postpartum anxiety, postpartum psychosis, postpartum stress, postpartum post-traumatic stress disorder. Postpartum depression occurs in 10 to 20% of women, and it leaves them feeling sad and hopelessness and loss of interest in everything going on around them, including their newborn. Fatigue, thoughts of self-harm or suicide even. Postpartum anxiety occurs in about 10 to 15% of new mothers, and that just leaves with excessive worry, both about the world around you and parenting and being a mother, and it leaves you restless, immense intrusive thoughts of horrible things. It can leave them with panic attacks and irritability. And then postpartum psychosis is about 1 or 2 in every 1,000 mothers, which doesn't sound like a lot, but it's a pretty traumatic thing to experience and to go through. And this can leave the mother having hallucinations, being delusional, rapid mood swings, and just react very impulsively to everything and every decision that is made. So when it comes to clinical diagnosis for reproductive trauma, not all women who experience adverse reproductive experiences will meet the DSM-5 criteria A for official PTSD diagnosis. So let's say a woman is just experiencing infertility, there's no direct loss or threat to life, so that doesn't meet criteria A. Same thing with postpartum mood disorders. Recent studies have really pushed to prove that women who do not experience a direct loss or a threat to life still do experience post-traumatic stress symptoms, and they meet criteria B through E for clinical diagnosis. And then additionally, Dr. Janet Jaffe notes that while not all fertility and pregnancy loss patients meet the full criteria, so they may not even meet B through E, they're still traumatized by their experiences, and a broader definition of trauma is helpful for clinicians when diagnosing and treating clients who are coming to you with these reproductive traumas moving forward. So 5 to 6% of postpartum women experience childbirth-related PTSD. That is pretty significant as a diagnosis, a statistic of actual diagnoses. So these women are left with intrusive symptoms that cause recurrent distressing memories, dreams or flashbacks to these incidents. They experience intense, prolonged distress and or psychological reactions and physiological reactions as well. They can experience sweating or nausea or trembling. So they're kind of reacting on all levels. And then they're also going to experience increased feelings of hypervigilance, irritability, inability to concentrate, or sleep disturbances even. So miscarriage, stillbirth, and traumatic birth experience do meet the criteria for both DSM-5 and the ICD-11. So with miscarriage and stillbirth, obviously the mother is experiencing a direct loss of their child. And with a traumatic birth experience, the woman could have experienced a threat to her life or a threat to the babies if an emergency C-section was performed for the child's sake, or if it was performed for the mother's sake, or if the mother was hemorrhaging, or they had to perform a hysterectomy within surgery to stop bleeding. These are all threats to life and do then qualify for criteria A. So infertility does not alone meet the criteria for the DSM-5 or ICD-11 alone. Infertility can run concurrent and combine with, like I said before, another trauma that could then lead to a PTSD diagnosis, but again, alone it does not meet that official diagnosis. But infertility, like I said, can include those constant cycles of hope and loss and hope and loss. Every month you hope this is the month, and then every month it's not, and then the next month you hope it's the month, and then it's not. These are constant cycles that really affect a woman. And then if you pair that with a perinatal loss, it's going to meet that criteria. Up to 40% of women who are experiencing fertility have a psychiatric diagnosis. Common diagnoses include major depressive disorder, which is 17 to 19.5% of women of infertility women meet that criteria. 23.2% meet the anxiety disorder diagnosis, and 9.8% meet the dysthymia diagnosis. And suffering from infertility can increase the risk of psychological distress during pregnancy and postpartum should this woman get pregnant, because there's so much stress from the back end of trying to get pregnant. They're just at an increased risk of then experiencing major mood disorders during and after pregnancy as well. And then infertility impacts the relationships around them as well. So postpartum mood disorders, again, do not meet the DSM-5 or ICD-11 criteria alone, but they can run subsequent or concurrent to reproductive trauma. It's a spectrum of mental health conditions following childbirth. So there are several risk factors to developing postpartum mood disorders, including the patient's previous depression or anxiety history, trauma history. So like I said, if it runs subsequent to a traumatic birth, that can meet the criteria, as well as their biological factors, psychological factors, and socioeconomic factors. Those all play a role into a woman's potential to develop a postpartum mood disorder after giving birth. So in looking at treatment for reproductive traumas, adequate and timely mental health treatment is critical for all reproductive traumas. Untreated traumas relating to fertility, pregnancy, birth, and postpartum can increase the risk of depression in subsequent pregnancies and perinatal periods. So if a woman has not been treated for her traumatic birth from her first pregnancy, she is at a very high increased risk of developing depression or anxiety in her next pregnancy or her next postpartum period as well. So it is crucial and critical to timely treat the mental health of new mothers. Some interventions that can be used. Trauma-focused cognitive behavioral therapy is useful in reframing and restructuring thoughts after experiencing a trauma or a loss. It helps clients see their value even after everything they've been through. So it can be helpful in fertility to see their value even after their inability to get pregnant. Perinatal dialectical behavioral therapy focuses on the emotional regulation and coping skills that promote mother's mental health. It can be used to decrease maternal anxiety and depression. It's very useful during and after pregnancy with those mood disorders. Eye movement desensitization and reprocessing, EMDR. This is the most helpful for trauma specific. So this is used specifically for like birth trauma, loss. You're not necessarily going to dive into this with a postpartum mood disorder unless it's compiled with a loss or birth trauma. And then interpersonal psychotherapy. It focuses on coping with problems that have been caused by loss, change, or relationship conflict to improve the functioning of the interperson. It's considered highly effective in treating anxiety and depression, both during and after pregnancy, grief and loss during the perinatal period, and it is very beneficial in treating role and relationship transitions in a couple that can come to problem during fertility treatments, during a mother's post-traumatic stress, if that is present. So it's very helpful in treating the mother and the couple or family as a whole, if need be, as well. So here are our references. Basically, studies just need to continue moving forward to try and make sure that we are treating women's experiences as trauma, even if they don't experience a loss. So, infertility can be traumatic. Those mood disorders can be traumatic, both for the mother and the family as a whole. So it's important that they just continue our research, and we kind of, like Dr. Janet Jeffy said, focus on trauma as a whole and give it a broader definition in order to best help all women and new mothers.